Good afternoon, everyone. If you would take your seats, please. Thank you so much. I think everybody's signed in. If you haven't had an opportunity to sign in and you're already here, make sure that you sign in. It's with great pleasure that I introduce the Dean of the College of Health Sciences and Human Services, Dr. John Renaud. He's going to come and give you a welcome.
Thank you, Dr. Rodriguez. I'd like to begin the session this afternoon with a quotation from the Institute of Medicine, and I quote, "Efforts to improve patient care and population health are traditional tenets of all the health professions. But in a time of rapidly changing environments and evolving technologies, health professionals and those who train them are being challenged to work beyond their traditional comfort zones and often in teams. A new professionalism might be a mechanism for achieving improved outcomes by applying a transdisciplinary professionalism throughout healthcare and wellness that emphasizes cross-disciplinary responsibilities and accountabilities. Such a professionalism would facilitate multiple disciplines working together, each using its own expertise to address common problems." End quote from the Institute of Medicine. I think that sums up very well a sea change. I know we tend to overuse the term paradigm shift, but I think it is accurate to say that this session today reflects a paradigm shift that is occurring across the nation, if not the globe, in healthcare, education, and practice. It's variously called interprofessional education, interprofessional practice. The two are very much aligned. And that's what our faculty, very much to their credit, and the faculty get 100% of the credit today for pulling this session together. And I really believe it's a monumental day for UTPA and certainly the College of Health Sciences and Human Services. To my knowledge, it's the first in the history of the college where all of the disciplines, all 9 disciplines, academic disciplines in the college, have collaborated to present a case as to how each of these disciplines would approach it, which is really what interprofessional practice is all about. It is a delight and an honor for me as Dean of the College faculty for this tremendous effort and this tremendous event today. I'm very impressed to see all the white coats and all the brown coats and all the non-coats representing students from every discipline in the college. It's very, very exciting. I think the excitement is palpable in the room, and I think it reflects the energy around the interdisciplinary activity. You know, with the medical school coming into the Valley and the new university, this effort could not reach a crescendo at any better time. The college is starting an initiative on interprofessional education and practice, a council on that topic, so you're going to hear a lot more of it from our college. Again, 100% of the credit for this event goes to the faculty. As always, there were a small group who played a tremendous and extra leadership role, and I want to recognize Dr. Melinda Rodriguez from the Department of Nursing, Dr. Shirley Wells, and also the department head from occupational therapy. And Dr. Audrey Jones, physician assistant studies, and also our clinical coordinator in PA. Those folks played the major leadership role. Again, it's a pleasure to be here and to welcome you, and without further ado, I'd like to turn the podium over to Dr. Melinda Rodriguez.
We're very happy that everyone is here. And at this time, I'm going to take a little bit of time to just tell you the importance of the evaluation. If you didn't get one today, don't worry about it. We ran out, and I think that's a good thing that we ran out. If you did get one, we expect you to fill it out, and please turn it in at the end of the session. I'd like to take this time to introduce the faculty, and as Dr. Renaud said, I want to echo the fact that without the faculty, we could not have done it. And there are certain people that I'd like to recognize. I'm going to introduce all of the faculty. I want to thank Dr. Terry Mata-Pistocache from speech, who really helped in putting the slides together. I can't tell you how hard it was to do that. And she had some of her research students do it. And so if you're out there, I'm sorry, I apologize, I didn't write your names down. But thank you so very much. Your work was well recognized, and we thank you. We also had some outside clinicians that are coming to help us, and I'm going to introduce them now. When I say your name, if you'd please stand, and I'd like to introduce, first of all, Dr. Betty Bautista. Dr. Betty Bautista has been teaching in the Master of Science Nursing program since 1999. She is also a practicing family nurse practitioner, and she has been teaching. She was my teacher. Not to say anything about Dr. Bautista's age, because we're the same age, but she was my teacher, so she's been teaching quite a while. The next presenter, I'd like to mention Dr. Lilia Fuentes. Dr. Lily Fuentes got her doctorate in nursing practice from the University of Health Science Center in Houston. And Dr. Bautista got her DNP from the University, Rocky Mountain University Healthcare for Professionals. So back to Dr. Fuentes, she got her DNP. She's also the coordinator of the MSN program. She's been teaching in our program since 2004. Thank you, Lily. Dr. Jack Runyon. Dr. Jack Runyon is with the Physician Assistant Studies Department. Dr. Runyon has been teaching, I know, for a while. I don't know, Dr. Runyon, how long, but he has also taught some courses for our Master of Science in Nursing program, and he also supervises students in clinical. Dr. Daniela Basan with the Cooperative Pharmacy program. Dr. Basan is a lecturer in the Cooperative Pharmacy program, and we want to thank you, Dr. Basan. Ms. Chelsea Alamia. Ms. Chelsea Alamia is a registered dietitian. She is also Ms. Pam Sullivan's daughter, and we really want to thank you, Chelsea, for helping us. She's going to be covering the role of the dietetics or dietitian. Dr. Shirley Wells. Dr. Shirley Wells is the chair of the Occupational Therapy Department here at Pan Am, and has helped us in developing the objectives for the IPED. And thank you so much, Dr. Wells. She also was able to get Mrs. Evangeline Carlson, who is a physical therapist. She is the wife of Dr. Don Carlson, who teaches in the occupational therapy program, and we want to thank you so much for helping us today, Mrs. Carlson. Also, I want to mention Terry Mata Pistocache, Dr. Pistocache, Mata Pistocache. And she is a clinical faculty, I believe, and she also consults, takes care of her students or graduate students in the speech or the ComD department. Dr. John Gonzalez, who is with our social work department. And Dr. Jerry Fisher, who is the coordinator for doctoral studies in rehab counseling. And last but not least, Dr. Audrey Jones, who is our medical director for the PA Studies program. So without further ado, I'm going to go ahead and ask for our first speaker. Dr. Beatriz Bautista will come and begin the session.
Good afternoon. This is something that we're making history today. I just want to quote the definition of interprofessional education from the World Health Organization that says it's an experience that occurs when students from two or more professions learn about, from, and with each other to improve the health and safety of patient, maximizing the strength for each discipline. And that's really what we're trying to do today. We're doing today is bring in all the professions so that you guys can see the role that we play. As a family nurse practitioner, we're actually healthcare providers, so we see patients in a clinical setting, acute setting, ICU, and a lot of different settings, and we provide care. So this patient that we're talking about today, Mrs. J, was my patient in an outpatient setting. I saw her for different visits, maybe routine visits, some episodic visits that she came in to see me. So I'm glad to be able to participate today and introduce our patient to you. So I think I have the, there we go, that's my slide. So our patient profile today is Mrs. J, a female. She's 81 years old. She is resided in Alamo for many years. Baptist insurance. She had Medicare, Medicaid, Medicare, and Blue Cross Blue Shield. And the informant today, as she presents to the emergency room, I'm the family nurse practitioner working in the emergency room. So her daughter brings her in, and so her daughter is the informant. The chief complaint is what basically that she's unable to verbalize and appears to be paralyzed from her right side. And so her daughter is the primary historian here. History present illness. So Mrs. J is a 79-year-old that had been in the local hospital's rehab center floor for 2 weeks. She was recovering from a right-sided hip replacement. So she had surgery, and she had to go to the rehab because she had to learn to walk again after the fracture of her hip, and they did surgery on that. She had been doing well during her rehab for the first week, but in the second week, she developed a progressive shortness of breath. She also, so at that time, she was transferred to the emergency department of that hospital, and she was found to have had an acute MI. So she had a heart attack. But after the studies showed that there was no significant damage to the wall of her heart. So she went back to the, after being in the telemetry floor, she was transferred back to the rehab to complete her program of trying to walk again. And 2 days later, on the evening of September the 2nd, this is a year ago, she developed sudden aphasia, which basically that's when we saw her in the emergency room. She couldn't speak, and then she had right-sided paralysis. A little bit about her past medical history that's relevant to her care, because as interdisciplinary group that we're going to be talking about her and trying to make the best health plan for her. And so as a child, she had asthma, and we're going to see a little bit about this later, but and it kind of resolved at 8 years. She has no known allergies. She has a 25-year history of controlled hypertension, and I saw her for these visits, did her regular 3 to 6 month lab chemistry, and she was controlled on an ACE inhibitor, and pharmacy is going to talk a little bit about her drugs in a little bit, beta blocker. And then she also had a 30-year history of dyslipidemia, hyperlipidemia, and she was taking a medication for that too, also controlled. She suffered from gastroesophageal reflux disorder. She has osteoarthritis of multiple joints. She also had cataracts, but she was treated successfully with surgery. She had osteoporosis, and I saw her quite a bit for this, and I treated her. Her osteoporosis was complicated by smoking, and she also, because of her COPD, had to take steroid medications, and we know the steroid medications cause a lot of bone thinning, and so so her medications we treated her for her osteoporosis. 15-year history of chronic obstructive pulmonary disease. She did have a 20-year history of smoking 2 packs of cigarettes a day, so that makes her a 40-year history of smoking. And so that complicated a lot of other things like her heart and her lungs and her bones. She also had an 8-year history of atrial fibrillation, secondary to her sleep apnea. So she also had sleep apnea, and she was on drugs for that. She had a TIA with no deficits earlier that year, June of 2012. And then, of course, her recent MI that she suffered prior to her visit back to the emergency room. So a little bit about her surgical, past surgical hospital history. Appendectomy at 20. She had a hemorrhoidectomy at 35. She had numerous visits to the hospital and to the clinic where I was at. for COPD exacerbations, and we treated her. She was doing fine. And then at 65, she also had bilateral knee replacement because of her osteoarthritis. She had vertebroplasty with her 5 lumbar vertebrae, secondary to osteoporosis, and that's when I saw her too, at age 70. And then the last time that, when she was in the rehab, she had her hip pinning at 75 after she fell. And her replacement, hip replacement was she came back and she had to have it replaced because when she had the pinning, it didn't quite work. She had one leg a little bit longer than the other one, so they had to go back and fix her hip again. So that's when we saw her here. And of course, obstetrical history, she had 3 pregnancies and 4 children. That means that she had twins. So a little bit about her social history. We want to know Mrs. J. She was born in Kentucky, Caucasian, marital status. She lived with her husband of 60 years independently. Her occupation, we were very proud of her. She was an RN, and she had 3 masters in administration. She was a family nurse practitioner. She was also a psychiatric nurse practitioner. And of course, she was a former UTPA faculty here, so I met her here when I started as a junior faculty here. And her interests, she liked reading, and she also liked genealogy. Habits, of course, we talked about her history of smoking. Didn't drink much, just whenever she went to parties, and no illicit drugs. Her diet, actually, she had a good appetite, so before all this happened, she was eating a regular diet. Family history, nothing really. Her dad had, at 62, had cirrhosis secondary to alcohol use. Her mom died at age 45. A car hit her, and so she died prematurely as a pedestrian. Her sister had breast cancer, but she's still alive and well. And she had one brother at 69 that we don't know what he died of at this point. So a little bit of her review of systems. Basically, again, it was her daughter that told us about what was going on because Mrs. J couldn't speak. So the general weakness on her right side, and she's trying to speak, but she couldn't speak. No fever, she hadn't had any chills. Nails, all that, nothing had changed. Head and neck, her right side, she couldn't move her right side, her right arm. Eyes and ears, nothing there that we need to discuss at this point for her plan of care. And her chest, her lungs, she was not having any difficulty breathing. She was controlled on her anticholinergic for her COPD. Occasional cough, but nothing more than that. Hematology, lymphs, no changes in there. GI, she didn't have a change in her appetite. Like I said, she was eating a regular meal. No problems with her bowel movements, no constipation. GU, no dysuria. She didn't have a Foley. She wasn't incontinent, so she was pretty much doing her own thing. Neuro, again, it was her right-sided difficulty and unable to verbalize, and her mental status, because she was confused because of what happened with her CVA, was she couldn't follow simple commands. She was not able to respond to us. So medications, again, she was taking some acetaminophen, PRN for pain for her joints, Bystolic. On Fosamax, she was taking that for her bones. Recently, she had been treated with Fortil for 2 years and then put on Fosamax. Lisinopril, again. Pradaxa is the one that she was taking for her AFib, and then statin for her cholesterol, Spiriva for her COPD, and Zantac for her GERD. So her physical assessment, basically in general, I noticed that she was unable to respond on her right side, and she did appear a little anxious, and we felt that it was probably because she was trying to speak, but nothing would come out. So mental status, unable to assess at this point. We couldn't figure out if she was oriented or not. But she wanted to speak and couldn't speak. Skin, hair, nails, nothing there. Everything was good. Her turgor was good, moist. Her nails were pink. Good brisk refill. And head and neck, Her head was erect, but again, her left side was a little bit, right side was a little bit paralyzed. And thyroid, trachea was midline, nothing enlarged there, lymph nodes, and her left side, she had full range of motion. Ears, nose, and throat, no tearing. Her eyes were pretty much unremarkable. There wasn't anything there that I noticed there. No flaring, no problems breathing. Her tongue was midline, uvula was midline, no fasciculations. When somebody has a stroke, we look at that. Her gag reflex was intact. Chest, AP diameter, she was a little bit barrel chest, but that was because of her COPD. Respiratory breathing was easy and comfortable. She was not having any problems and no retractions. And her inspiration-expiration ratio was 1 to 2. Tectal fermentus symmetric, and a little bit of hyperresonance on percussion throughout her lung fields. Breast, unremarkable. Heart rate, apical pulse, barely palpable at the 5th intercostal space, 4 centimeters from the mid-sternal line. Her rhythm was a little bit irregular. She didn't have any heaves, lifts, thrills. S1, S2 was heard on the 5th again, and she did not demonstrate an S3. Blood vessels, again, normal. She was a little irregular, no carotid distension, renal, abdominal bruise, none auscultated, and no swelling or tenderness to her lower extremities, negative Holman sign, extremities warm, some superficial viscosity to her lower extremities, and abdomen was round, soft. She did have a faded scar where she had an appendectomy. Aorta was midline, no visible pulsations, no bruise. Bowel sounds were heard on all 4 quads, and her liver span was not enlarged. Everything else was pretty normal for her age. Genital rectal was deferred at this time, and lymphatics, again, no nodes appreciated in any of her areas. Musculoskeletal, she did show some signs of osteoarthritis. And so, and then of course her right side was weak and she could not move that. The deep tendon reflexes were absent to the right side of her extremities, but normal on her left. So neurological, again, she had the deep tendon reflex absent. So what we did is we ordered a CT of the brain without contrast, and at the time we ordered it, it was normal. The first time we ordered it, it was normal, the initial one. We also did a CBC to figure out what was going on for any infections, anemias, all that stuff. They were essentially normal. Her CMP was also normal. There wasn't anything significant there. Urinalysis was also normal. PTT essentially also normal. Her carotid Doppler studies had been done about 6 months prior to her this episode, and basically it came out it was negative. There wasn't any blockage there. And so her differential diagnosis at this point was TIA versus CVA, which is your the first diagnosis that we had there, aphasia, of course, right, hemiparesis. She also had atrial fib. So all these diagnoses are important when we admit her, because depending on what she has, we're going to have to order stuff for that. And so, again, it's just a repetitive of the first diagnosis that I gave you: hypertension, hyperlipidemia, COPD, GERD, and osteoporosis. So our plan was, basically my plan is to admit to intensive care. We're also going to do a neuro consult. We're also ordered and considered the TPA therapy for her stroke. And the week in the ICU, we also have consulted with physical therapy, speech therapy, and they're going to come in after me to talk about what they did with Mrs. J. Swallowing studies, especially because of that dietetics, need to make sure that she can swallow so that we can feed her. And then Dr. Runyon is going to talk about what we did after she was there, because he did some hospital rounds, and he's going to give us the results of a lot of these studies. And what they did to transfer her to the nursing home, and then the rest of our disciplines will talk about what happened afterwards. So I'm glad to introduce Mrs. J to you guys. So.
Well, thank you for having me. Just to echo what Dr. Renaud said, this environment in this day and age of healthcare reform is, for most of us in the healthcare professions, part of our accreditation nowadays is that we have to have some interdisciplinary type of training, because it is expected that we will be doing interdisciplinary team approach to patient care forever and ever. Regardless of what you think of Obamacare and where it's going, the interdisciplinary theme is going to be present no matter what. So with that in mind, I am the physician assistant working for the neurologist. Of course, neurology has been consulted, and so as the PA working for the neurologist, I'm going to make rounds the next morning at the critical care unit where Mrs. J is residing now. She's remains, when I go to see her, I read Betty's note and read the complete history and physical that she's written. For our students, you notice that she did a complete history and physical. And as I've said before, that complete history and physical has to be done with every admission to the hospital. The very next morning, I find her unimproved. In other words, she remains aphasic. She is having difficulty following commands. She wants to, but she can't. She can't move her right arm, and in fact, she has it kind of drawn up in a flexion of both the wrist and the elbow. She can't move her right leg, and we'd ordered a second CT scan after the initial one was done in the emergency room. When she got up to the critical care unit, a second CT scan was ordered for the following morning, which is when I'm there, and that CT scan has been done. By the time I get over there to see her, the CT scan hasn't been prepared yet and hasn't been read by the radiologist yet, so I'm going to go ahead and examine her before, and then go check on the CT scan. She doesn't appear to be in any distress. She remains aphasic. She has a leftward gaze, but she can't follow commands for her external ocular movements. She can't stick out her tongue for me. Her neck is stiff, but I can manually move it. She can't do it voluntarily, and her eyes remain. Her eyes are moist, but without any erythema. Her lungs are clear. They're clear bilaterally, and I don't hear any wheezes, rales, or rhonchi. Important because she is a COPD patient. She continues to have an irregular rhythm on auscultation and palpation. Again, as with the initial physical exam, I don't hear any clicks, and I don't hear any gallops. Her rate's 92, but it's irregular. Abdomen soft, not tender. I don't feel any masses or megaly, no abnormal sounds at all. Of course, I referred doing the GU and rectal, as did the initial evaluation. Extremities, as I said, her right arm is contracted, stiff. She doesn't have any clubbing or cyanosis, again important because she has a history of COPD or edema. Neurologically, I can't measure her cranial nerve status because she can't cooperate with the examination. Cranial nerve status is something that we would like to get a good view of, but if she can't cooperate, then she can't cooperate. She's sensitive to a pinprick on the left, but not on the right, and there appears to be normal motor function on the left, but she can't respond to commands to do any of those motor functions. I can't get her to grab my hand or what have you. She just can't respond. Can't get a psychiatric evaluation because she can't talk to me. She's aphasic. So by now I've got my labs from the morning. Her CBC is okay. Her CMP, complete metabolic panel, is okay. She does not have any evidence of anemia. There's no evidence of any infection in her CBC. Her CMP doesn't give us any evidence of any renal or liver dysfunction. There's no elevated blood sugar, and there's no evidence of any electrolyte disorders. PT and PTT are normal, so her clotting studies are normal. Bear in mind she is on an anticoagulant. CT of the brain, this is the second CT scan that was just done, looks like this. Most of her left hemisphere is gone. You can see, and you don't have to be a radiologist to be able to see that. On the right side of the screen is a normal brain tissue. On the left side of the screen is ischemic stroke. You can see how that's distorted the ventricles of the brain, and it's actually shifted everything a little bit to the right. So now my differential diagnosis that I've got rolling around in my head is she's got an ischemic stroke. I'm pretty sure of that from the CT scan. But she could also have a hypertensive encephalopathy. Bear in mind that she is a hypertensive patient. She might have a seizure disorder, and she might have a brain tumor, so there might be a neoplasm there too. But we're going to keep that and rolling around in the back of our mind as a differential diagnosis. But we're pretty sure with our working diagnosis of an ischemic stroke, we are pretty solid because she has these risk factors for an ischemic stroke. Anybody with atrial fibrillation is always at risk for both MI and stroke, and she's already had an MI. She's on anticoagulation therapy, so that decreases her risk of ischemia of an embolic event from the atrial fibrillation. But bear in mind she's on anticoagulation therapy, so any bleed is going to be heightened with the anticoagulants. She is hypertensive. Anyone with hypertension is at risk for a stroke. She does have hyperlipidemia. Hyperlipidemia, of course, puts her at risk for any kind of occlusive injuries, regardless of whether they're brain or heart. Anyone with an MI is also at risk for a stroke. An MI increases anyone's risk for stroke. She's had a recent surgery, a total hip replacement, hip replacements, or any kind of orthopedic surgery seems to increase the risk of embolic events no matter what. She has a family history of strokes with her grandparents. She does have a history of osteoporosis, which may have increased her risk for falls, which in turn may have increased her risk for ischemic event. And she has a COPD/asthma history. So she's been a heavy smoker in the past, and we know that increases our risk for almost everything. Now, when we have her in this critical care unit, of course, we're still going to continue to take care of all her comorbidities. So we still have to manage her hypertension. We still have to manage her COPD. We still have to manage her atrial fibrillation. And part of the reason we need to keep her in the critical care unit is so that we can monitor her blood pressure and pulse and any changes in her mental status. Most hospitals and critical care units will have a stroke protocol for the nursing staff, and that means that that's going to time how often they're going to check all of those things. It might be every 15 minutes for the first 2 hours, and then every half hour for the next 2 hours, and every hour after that, and so on. But she's going to be monitored almost on a one-to-one basis, depending on how busy the critical care unit is. We also, because of her atrial fib and because she's had a stroke and because she's had an MI, we got to cardiac monitor her, and if for no other reason, we need to make sure that her atrial fib is at least under some type of control. Whether we're managing her atrial fib per se or we're managing her ventricular rate because we can't manage her atrial fib, we still have to manage that. We want to measure her intake and output, so the best way we can measure output is with a Foley catheter. We're still uncertain about her swallowing status. Bear in mind that she could not follow any of my commands for cranial nerve studies, so I'm not sure whether she can swallow even liquids appropriately. So we need to maintain her hydration, so we have to have her on an IV. She'd have to be on an IV to be in the coronary critical care unit anyway. We'll want to give her oxygen to make sure that she is staying well oxygenated, and bear in mind that she has COPD, so we have to be careful about how much oxygen we give her. Of course, she's going to be on bed rest. What about anticoagulation therapy? I put the question mark there because when the pharmacy gets up here, they're going to talk a little bit about what we want to do with anticoagulation therapy. This is an ischemic stroke, but bear in mind her medications that she was on before she came in, and also that we are continuing to monitor and take care of all the comorbidities, let alone the reason she's here right now. We agree with the emergency room nurse practitioner's initial assessment that we need to have some physical therapy, occupational therapy, and speech therapy to start her rehab ASAP, and speech therapy to monitor her swallowing status too. We also want to consult social services. She's going to have to get out of the hospital at some point, and we want to consult rehabilitation because we want to find out what we're going to do with her long term, what she's going to do long term. And with that, I move on to the nursing department and what their role is going to be.
Okay, guys, now it's the nurse's role. I know some of you know me as a nurse practitioner, but my role here is as a registered nurse in the ICU. Although it's been a long time ago that I was in the ICU as a nurse, but here we go. One of the things that I like to say is that as nurses, we pretty much do a lot. And I'm very happy to be a part of this IPED, or Interprofessional course that we're taking here, or workshop. And I also want to say that I've returned to my first love. As I was doing this PowerPoint presentation, I was looking at it and saying, this is going to be hard, this is going to be hard, because it's a different role that I had before. But as I was doing it, I remembered our first love as registered nurses, and how we worked in the hospital. Registered nurses are, and I just wanted to kind of give you a brief description of what our role is. Responsible for providing safe, compassionate, and comprehensive nursing care for patients and their families with complex healthcare needs. The scope of practice is there. I'm not going to read through that. But one of the things that I'd like for us to remember, or those of you that don't know what a nursing process is the nursing process is pretty much the framework of how we approach patient care. It is pretty much a 5-unit thing that we have, and it kind of intertwines with each other. It's assessment, nursing diagnosis, planning, and implementation and evaluation. As patients come into our unit, we develop a nursing care plan that pretty much constitutes this systematic method of being able to plan and provide care for our patients. And within that, critical thinking is a big part of the skills that we use to be able to come up with this care plan. Communication is also something that we have to be in tune with our patient. But before we really look at what our patient is, we really have to look at what stroke is and how the severity of stroke. It is the 4th leading cause of death in the U.S., and it is the leading cause of disability for Americans in the U.S. It kills about 130,000, probably more than that, and that's pretty much the number that I looked at each year. And about close to 800,000 people actually have a stroke each year. For the most part, the majority of these people are usually a first or a very new stroke. 87% of the strokes are actually ischemic, which, we have this patient is pretty much an ischemic stroke. And the thing about it that really struck me is the fact that, stroke costs in the U.S. is anywhere between $32 billion to $65 billion. And this is indirect and direct costs. So it's a pretty severe type of blow to our patients and to America. Risk factors, of course, one of the things as nurses we promote health, and that's one of the things that is embedded within nursing. So one of the things that we look at and identify as risk factors and do a lot of patient education regarding risk factors. Of course, age, heredity, sex and race, smoker, prior stroke or a TIA, which our patient had, or a heart attack, which also our patient had. Chronic illnesses such as diabetes, hypertension, hyperlipidemia, obesity, and others. And so we look at stroke that way. And so as nurses, our big thing is to really look, okay, let's go back and look and see what stroke really is. And this is what stroke brings to us. Now, the new patient admission, we get these orders from their healthcare provider. And this is a 79-year-old Caucasian female admitted to the intensive care unit due to aphasia and right side hemiparesis. Admitting diagnosis is pretty much, TIA versus CVA, and I know a lot of the times you see that in orders. They don't really know what's going on, so they can kind of gather what they're trying to rule out. But, secondary diagnoses are also very important, so you'll see that on those orders. And so some of her secondary diagnoses are your atrial fib and is on an anticoagulation therapy, so that's very important to identify. Hypertension, hyperlipidemia, COPD, GERD, and I know there was a few others there. Also, the big thing that we look at is code status. As nurses, we pretty much, we're gatekeepers to patient information within the hospital. Although now, the word is a patient advocate, and we've always been patient advocates. And so we have to make sure that we speak for our patients, especially with this patient that, perhaps can't speak. She can't speak, can't really communicate. And so the code status becomes very important. So that's when we really touch up with the families to try to figure out, what kind of code status is this patient. Allergies, very important. We look at allergies to see if, she has any allergies. Admitting orders pretty much cover, a whole variety of things. Cardiac monitor becomes one thing, so, we have to make sure that we get those on the patient. IV access also, we have to make sure we use, the biggest IV access on her because we don't know what we're going to be, having to do with her. So IV access becomes a very important thing, sometimes one or two, maybe a saline lock and an IV access for IV fluids. Neuro checks. I know that every hospital, every ICU unit has their own protocol for stroke, patients. And so neuro checks become very important. Vital signs and neuro checks become very important. So we may be doing them every 15 minutes for the first hour, second 2 hours, every 30 minutes, every hour on the hour. But for sure, when they first get admitted, it's pretty much every 15 minutes. It's pretty much the overall, consensus. O2. A lot of the times we have to really, call respiratory, get respiratory in to make sure that we have this patient on O2. Sometimes, as ICU nurses, we pretty much do it all, don't we? We always pretty much do it all. Intake and output, she's on a Foley catheter, so we're going to have to make sure that, we have accurate intake and output. So that's one of the other things that we actually do. Sometimes is every shift. But overall, we look at it every 24 hours. Activity, what kind of activity is this patient going to have? This patient's pretty much going to be bedridden. So, that's pretty much a standard order for this because of the fall risk involved. Diet, pretty much a lot of the times when patient gets admitted as a stroke, we're not going to really, she's going to be NPO until we really have a solidified, results of the swallow studies or the CT scan. Weight, we have to weigh this patient at the beginning or when we admit her, weigh her, and then after that, perhaps every 24 hours, every day, weigh. But for sure, it has to be weighed at the very beginning. Labs, we looked at some of the labs that were ordered, but some of the you know, the labs that have to be ordered, CBC, PT, PDT, INR, CMP, some of those orders. And so we have to make sure that we call in the lab personnel to come in and get those quickly. Tests, we have to prepare the patient to get into the CT, EKG, make sure that that wasn't done. If it wasn't done in the emergency room, if it was already done. If it wasn't, then, you know, we need to make sure that she gets it done. You know, and then we also have to get all these people, we initiate contact with physical therapy, occupational therapy, speech therapy, social work. You know, we pretty much get everybody involved at that point. Assessment, I'm not going to really go over assessment because I think Dr. Bautista and Dr. Jack Runyon have already gone through that, but I just want to say, you know, kind of the foundation of what we do. When we first admit a patient, you know, we look at the health history, we look at risk factors and previous strokes, and, you know, she hadn't had one. TIA is what she had had. Drug use, we look at prescribing over-the-counter medications, smoking history, and then also when the manifestations began. Presence of incontinence, any family support system becomes very important, especially with our stroke patients, because we may not be communicating as much with the patient, although we do have to keep the patient involved in everything that we're doing, but we really need to direct a lot of our information with the patient. Advanced directive or medical power of attorney becomes something that we have to be very well aware of as well. In our physical assessment, we look at stroke scales, and I'm going to talk about one in a little bit. The level of consciousness, the vital signs, motor strength, coordination, communication, cranial nerves, sensory function, skin integrity, and then mobility status is pretty much, you know, what encompasses our assessment, our physical assessment for this patient. The NIH stroke scale, or NIHSS, is an 11-item scoring system. It integrates components of the neuro exam and other neurological components, and the maximum score is a 42 and the minimal is a 0. It pretty much looks at level of consciousness, the best gaze, visual field, facial paresis, arm and leg motor function, limb ataxia, sensory, best language, dysarthria, and then extension and attention. This is what, you know, some of them look like. And one of the main things that as nurses, when we do a stroke scale, is when you have the first response, that's pretty much what you jot down, whatever response you get immediately. You don't really kind of wait and say, well, did I see that right? Let me do this again, or let me ask this again. You pretty much, the best way to do that is to make sure you jot down the first response. And one of the things, like I said earlier, you know, we have the process or nursing process. So we look at the patient, we approach it in a different way, and in the sense that there's nursing diagnosis and intervention. One of the nursing diagnoses that we look at and we develop a care plan for is the risk for ineffective tissue perfusion. We need to monitor respiratory status, O2 saturation, airway patency, auscultate the lung sounds, and then also look at the ABG results to make sure that, you know, there is no risk for, you know, any kind of aspiration or anything that's going on with her. Suction as necessary, carefully not to suction more than 10 seconds, and one of the reasons, I mean, the main reason for that is because suctioning more than 10 seconds may increase the intracranial pressure, and you don't want to do that because at that point, you know, you may worsen what's going on in her brain. Place in sightline position, administer oxygen as prescribed, monitor mental status and level of consciousness, and that's pretty much why we do neural checks and vital signs pretty often in the ICU. It's every 15 minutes. If it's every 15 minutes, guess what we're doing? Every 15 minutes. Assess for pain, headache, continuously monitor cardiac status, monitor body temperature. There was an article that the evidence base saying that anybody who had temperature higher than 37 degrees Celsius was actually, you know, it really was considered to be a worsening type of stroke or, you know, rehab or progression. Maintain accurate intake and output records. Another nursing diagnosis that we also look at is impaired physical mobility. Patients cannot really use her right hand, cannot really, you know, get up. So one of the goals is to maintain and improve functional abilities. encourage some active range of motion exercises. You turn every 2 hours. You know, some of the common things that we do as nurses. Collaborate with physical therapy to see how much, you know, what else, some other exercises that we can do to help maintain that functional ability. Self-care deficit, bathing, dressing, feeding, and even toileting is also going to be impaired. Goal is for the patient to perform as much of their own physical care and grooming. We need to promote functional ability, increase independence, decrease any feelings of powerless, and improve that, you know, helps them improve self-esteem. And all of that actually helps this patient to you know, have a better outlook, you know, regardless of where she's at. So this is our goal. This is what we plan for our patient. Impaired verbal communication, as I said earlier, one of the things that we have to do as nurses is, you know, we have to utilize a lot of our critical thinking. We have to have very good critical thinking skills and very good communication skills. And so when a patient has an impaired verbal communication, our goal is to be able to keep communication with the patient. Collaborate with speech therapists, utilize other methods to be able to really communicate with our patient, writing on a pad, you know, just giving instructions on how to answer if, you know, if she can't answer. So we have to think of ways to be able to communicate with our patient. Impaired urinary elimination and risk for constipation. As I was writing this, I was saying, gosh, as nurses, we really do it all. We, you know, as nurse, I can put your bedpan, I can start an IV, and at the same time give you a prescription for, you know, for something as a nurse practitioner, actually. But just looking at that, thinking, it was like, wow, I'm in one of the greatest profession ever, I think. So great. Thanks, guys. Assist in using toilet facilities, administer prescribed stool softeners, you know, and also impaired swallowing. We have to make sure we you know, keep on top of what this patient, the results of any kind of swallow tests, studies. And then also when eating, simple as just sitting them up, you know, when they're eating. You know, make sure that if the patient is NPO, okay, fine, she's NPO. After the studies have been done, the physical therapist, speech therapist, everybody has been in contact with this patient and the patient's able to eat. We need to make sure that we really that look at the pureed soft foods and then make sure that the liquids are actually the same consistency. Assess for coughing with eating or drinking just to avoid any aspiration. And then having suction equipment available at bedside in case of any choking or aspiration. Those are some of the things that we do. And of course, discharge planning begins pretty much at the beginning when the patient gets admitted. We're always looking to see what this patient is going to require and then bring everybody into her case. Rehab center, you know, if she's going to the rehab center, and pretty much, you know, that's pretty much the case with, you know, stroke patients and with our patient. Physical therapy, speech therapy, occupational therapy, primary care provider follow-up, and in-home health services. And with that, I throw it to Dr. Daniela Bazan, PharmD. Thanks.
Hello, everyone. So my name is Dr. Basan. You know, I'm fortunate enough to work in an institution that actually does interdisciplinary rounds 3 times a week. So when the college decided to do this, I was very excited. And I'm here to discuss the pharmacy portion of Grand Rounds. So as a pharmacist, we are considered the drug experts. So whenever I get a case study like this, what we do is that we're going to evaluate all of the drug therapy. And within that, we can assist physicians in their pharmacotherapy decision making, so what they decide for treatment. We can monitor for drug efficacy and safety, evaluate for adverse reactions or drug interactions that may occur with a combination of medications that a patient is taking. We can be involved in monitoring for drug dosing, making sure that it's appropriate, and that the administration regimen is appropriate. We're involved in pharmacokinetic consultations, so that entails certain drugs require drug level monitoring that we can assist in. And then also we offer drug information to any part of the team that may need it. Okay, so let's get to the case. So in this case, a stroke patient, the first thing that would be done when the patient came in is that they would ensure respiratory and cardiac standpoint. Now that's important on our part because we would take a look and assess to see where the patient is at. And in this case, we know that Mrs. J did suffer a previous MI, that she has that history of atrial fibrillation, and that right now she's currently on lisinopril for hypertension, as well as the bystolic for because of the recent MI. So it's important as a pharmacist to know these parameters because in a case of stroke, it's actually beneficial for the patient to be a bit hypertensive to increase cerebral blood flow. And also we would want to be careful in treating to make sure that the patient doesn't become too hypotensive because that could affect perfusion to major organs, in which this case the most important organ would be the brain, right? So we want to increase blood flow. So this is important for us to know because if we were asked for a recommendation, we would have to know that we would only want to treat hypertension if it gets to if the blood pressure gets to a level of greater than 220/120. And in that case, if the patient was in that state, we would want to be very careful because of the previous MI. We wouldn't want to precipitate another one. So recommendation that we could give in this situation is to start labetalol. You can give that as PRN dosing or even start a nicardipine drip if the patient does get above that blood pressure level. Okay, so once we get that initial assessment, and let me add that this is all sort of happening at the same time because with stroke patients, time is of the essence. So when evaluating for TPA therapy, which is also known as alteplase, this is our thrombolytic agent that would break up the clot. You only have a 3-hour window of time. So like I said, all of this would be happening at the same time because as soon as the patient walks into that ER, we would have, the goal would be to decide whether we're going to treat within an hour. So it's called a door to needle time, and that would have to be decided within an hour. So for TPA, the indication is the management of acute ischemic stroke. This is very important because if it had been decided that, or diagnosed that the patient had a cerebral hemorrhage, then we wouldn't even be discussing TPA therapy because it is for an ischemic stroke, and that's if the stroke symptoms started within 3 hours, which in this case, the patient was already inpatient. They were on the rehab floor. So we're assuming that they did notice the symptoms within this 3-hour time frame. The inclusion criteria for this is the diagnosis of an ischemic stroke causing measurable neurological deficit. So we know that based on the symptoms that the patient came in with, and that the onset of symptoms was less than 3 hours beginning of treatment, and that the patient is 18 years or older. So in Mrs. J case, she did meet all these criteria. But now let's discuss the exclusion criteria. So we know that the patient was on Pradaxa or dabigatran when she came in. So that's one of the exclusion criteria. Because she was already anticoagulated, we wouldn't want to increase the risk of this patient for bleeding. So that would be something to consider. And then she also met these following relative exclusion criteria, which is that she had that recent surgery. So she was in the rehab because of that recent total hip replacement that she had 2 weeks prior to this episode. And also she did have that recent MI. So all of this puts this patient at a higher risk, along with the fact that she was 80 years old. You know, with more experience that we have with TPA therapy, the guidelines are now stating that you may want to do a risk to benefit ratio and maybe still treat if the patient did have 1 or 2 of these relative exclusion criterias. But in this case, considering the patient was already anticoagulated, she had just had that recent surgery, you know, she's an elderly patient, 80 years old, it was decided that this patient wouldn't be treated with TPA therapy. Another issue, like we discussed earlier, is that the patient had a history of atrial fibrillation, so that would also be addressed in the acute care setting. Where we lie in this is basically the physician would assess the patient and see if they are in normal sinus rhythm. If they weren't, then they would make the decision on whether the patient maybe needed a pacemaker, or we would treat it with drug therapy. And as the pharmacist, we would be involved in making recommendations as far as the drug therapy. Okay, so once you get past this first stage, the critical stage, we would start addressing other issues that the patient has with their medication. So the first thing we would do is do a medication reconciliation, and this is basically looking at all the medications that the patient came in with and evaluating what we would continue or what we would discontinue in the inpatient setting while the patient is being treated for stroke. So with stroke patients, the big issue is swallowing. She was on several oral medications when she came in, so we would evaluate those to see maybe which could be switched to IV therapy while she's inpatient, or which ones we can hold off on until a swallowing study has been conducted, which they'll discuss later. Other things that would arise in the ICU that we would discuss with the team is the need for stress ulcer prophylaxis. So the patient did come in with a history of GERD. We would assess that she is at a higher risk for GI irritation. Because she is anticoagulated, so we would maybe evaluate the need for IV Pepcid or famotidine. The patient was on Zantac coming in, but the Pepcid would be more cost effective for most hospitals. And also we would assess the need for DVT prophylaxis. So for we would assess her risk for clots. And she is already anticoagulated, so maybe the discussion would arise on whether she needed the sequential compression devices. Another issue, and this one is a big one for us because we're pretty much the only person on the team that looks at this, we'll assess renal function and see if any of her medications need to be renally adjusted. We know that she's on the Pradaxa, which would need to be adjusted if the creatinine clearance was calculated to be less than 30, and also the Pepcid would need to be renally adjusted if the patient had any renal issues. Okay, and this is what I was talking about earlier. So we would break down the meds and do a medication reconciliation and see what she's taking and what she's taking it for, and make sure that each drug has an indication and is necessary at this time. So that we know that she's on Pradaxa for the AFib. She was on lisinopril for hypertension, on Zocor for her hyperlipidemia. She was on the Spiriva for the management of COPD. She was on Fosamax for osteoporosis. She was on Zantac, PRN for her GERD, and she was managing the joint pain from the osteoarthritis with Tylenol. So, and like I mentioned before, all of these medications would be put on hold at least the first 24 hours until we figured out the patient's status and if she could indeed swallow. Okay, so once the patient is out of the acute care setting, we would look at what she was going to go home with. In this case, she was transferred to a nursing home. So again, the pharmacist would assist in doing the medication reconciliation and seeing what issues need to be addressed. I believe I skipped a slide. Okay, or maybe it just went missing. Oh, here we go. This is what I was looking for. Go back to our view slideshow. Thank you for that. This one? No? Thank you. We got it. I appreciate that. I know, that was like what we're talking about. We were collaborating on that. Okay. So I guess maybe one of my slides got misplaced, but I'll just keep going. So we were talking about each medication and what issues would arrive on discharge. So the first and most important one, because she is using this for anticoagulation, is the Pradaxa. So we would restart that within the nursing home, and of course we would discuss the greatest risk with this medication, which is GI bleed. Which is just bleeding in general. So that we would instruct the patient. In this case, the patient and her family were all healthcare professionals very well versed in medications, so it probably wouldn't require too much counseling. But in most situations, we would counsel the family on bleeding risk. So in this case, she just had that total hip replacement. She's at a high risk for falls. She would need to be very careful when being mobile, because she is at a higher risk. We would teach on watching out for signs of bleeding. Any unusual bruising or anything like that, she would have to in this case, let one of the healthcare professionals at the nursing home know, and they would assist her in watching out for that. Next, she's on the lisinopril for the hypertension, so we would evaluate where she is on that, if her blood pressure is being controlled. They mentioned in the initial assessment that it was being controlled, and just to continue monitoring the blood pressure. For the Zocor for hyperlipidemia, that's another medication that we would discuss the risks of that. In elderly patients above 65, you would want to be careful for the risk of myopathy. Simvastatin is also a drug where we would discuss drug interactions and make sure that there aren't any interactions with her other meds. So in this case, she had atrial fibrillation. So for example, if she was started on amiodarone, we would maybe adjust the dose on that. On the Zocor. For her COPD, is this where I was? Okay, the COPD, she was taking the Spiriva. This is another medication that would require caution in patients with any sort of renal impairment. And also we would discuss the need for assistance in administering this medication. So the inhaler is fairly easy to use, but it does require some coordination on the patient's part. She has to be able to place her teeth around the mouthpiece and close her lips around that. So she may need assistance until she recovers from the deficit caused by the stroke. And then we'll take a look at the Fosamax that she's taking for the osteoporosis, see if that's still required, or maybe we would consider discontinuing that medication just because she is at a higher risk for bleeding. She's being anticoagulated with the Pradaxa. So that's a medication that we would look at, because Fosamax does cause GI irritation, so that would put a patient at a higher risk for a GI bleed. Okay, and then also we would consider placing her maybe on a proton pump inhibitor. The patient did have that history of the GERD, so that could help her with that, and also play the role of a GI protectant. And then we would look at the management of joint pain. So we would see if the Tylenol is working to manage the patient's pain. Of course, we would want her to avoid NSAIDs. That could include like ibuprofen or naproxen. We would want her to avoid medications like that because those also do cause GI irritation. Okay, and in this case, the patient was transferred home, and she was transferred home with hospice care. And I just wanted to emphasize that the pharmacist could still play a role in this part when the patient goes home. So if she had developed, let's say, a wound infection from the hip replacement surgery that she had recently had, pharmacists may be consulted for antibiotic recommendations. And for example, if they were placed on a medication like vancomycin requires pharmacokinetic dosing, so we would assess where the patient is at renally and monitor drug levels. And we could assist with any other antibiotic recommendations. And then for pain management, so for the hospice care portion, a pharmacist could aid in recommending, opioid treatments, assisting in the combination that's often required to manage a patient's pain. So, like I said, I just wanted to emphasize, I kind of broke down my presentation into 3 portions: the inpatient care, the care that the patient received when they were transferred to the nursing home, and then once they were transferred home, and how the pharmacist can really be utilized in each of those roles. And with that, I am going to turn it over to nutrition. Thank you.
Hello everyone. My name is Chelsea Alamia, and I'm a registered dietitian. I work at Edinburgh Regional Medical Center. And today I'm going to focus on nutrition and the dietitian's role throughout Mrs. J's stay from rehab to ICU. What kind of things would the dietitian be looking at? going to start off with the definition of dietetics. And dietetics is the practical application of food science and nutrition, including the assessment of nutrition status, recommendation of appropriate diets, nutrition education, planning and serving of meals, food service management, as well as clinical applications such as enteral and parental nutrition. So you may see credentials. Oh, I'm sorry. Is this better? Okay. You may see the credentials RD or RDN. That means a registered dietitian or registered dietitian nutritionist. And these credentials are given to a dietitian who meets certain criteria by the Commission of Dietetic Registration. And those criteria include either a bachelor's or a master's degree that includes a comprehensive internship, and the internship has to be supervised and accredited by our credentialing board, and this includes about 1,000 hours of supervised practice, and there's heavy emphasis on clinical, nutrition sciences, chemistry, metabolism, those sorts of things. And a dietitian in the state of Texas is also required to be licensed. So you'll see RD, LD next to your dietitian's name. And dietitians can also hold board certifications like in pediatrics and nutrition support. So there's lots of different specialties out there your dietitian may have. Before we get into our case study with Mrs. J, I'd like to discuss a couple statistics with you in regards to malnutrition and hospital stay. 1/3 of patients admitted to a hospital are malnourished, and if left untreated, 2/3 of those patients will experience further nutrition decline. And among the patients that are not malnourished upon admission, 1/3 will become malnourished during their hospital stay. And as we know, malnutrition is associated with many adverse outcomes, including increased risk of pressure ulcer, impaired wound healing, immune suppression, increased infection rate, muscle wasting, functional loss, increased risk of falls, longer length of hospital stay, higher readmission rate, increased treatment cost, and increased mortality. So as you can see, having a dietitian as a part of this interdisciplinary team is crucial. Well, let's get into our case study, Mrs. J. So I'm going to start off in the rehabilitation unit. So Mrs. J is status post a right-sided total hip replacement, and I'm visiting her for the first time in the rehab unit. When I visit a patient in the rehab unit, I look for a couple things. The first thing I always look for is post-op nutrition decline, and it's quite common. And this includes things like decreased appetite, post-op nausea and vomiting, constipation, and I'll get this information by interviewing the patient, talking with the nurse, the physician, other members of the rehab unit, and I'll look at lab values and assess for any weight changes. I'll also see if there's any need for therapeutic diet, and I'll do this by reviewing medical history and seeing if there's any chance that I can do some education or intervention here. Looking at Miss J, some of the past medical history that jumps out to me is her history of hypertension, hyperlipidemia, COPD, and osteoporosis. So I'm assuming that Mrs. J is coming in as part of those 2/3 of the population that is not previously malnourished. So in this case, my recommendations for her would be a calcium and vitamin D supplement for the osteoporosis, and I'd also educate her on increasing calcium in her diet through things like milk and yogurt and cheeses, and a heart-healthy diet like low fat and low sodium. And I find that the rehab unit is a fabulous place for a dietitian to really intervene, because some people are usually in the rehab unit for anywhere from 10 to 30 days. So we can educate a patient and then continue to follow up with them once or twice a week and reinforce that education, so when we send them home, they've got a good head start on things. There's a slide missing. Slide missing. I'm going to talk about this one in a minute. But first, after a week in the hospital, Mrs. J had an MI, and she was taken to the telemetry unit. On the telemetry unit, I would then have to do a new assessment. Anytime a patient is transferred from one unit to the next, a dietitian needs to do another comprehensive look at the patient. Things change. So when she's taken to the telemetry unit, I'd visit her again. And the things I would look for would be any changes in PO intake. Has she still eating great? Is she not eating good? I would also look at her lab work and see if I can trend anything. I would look at her electrolytes, her cardiac enzymes, her serum proteins, for any further need for medical nutrition intervention. And at this point, Mrs. J was still doing well. She was still eating and her nutrition status was good. So I would recommend she continued on that heart-healthy diet. I'd also educate her on omega-3 fatty acids. She just had a myocardial infarction. So omega-3s are shown to reduce inflammation in the acute phase, and also they're part of the ATP3 guidelines for myocardial infarction. So I'd recommend she increases dietary sources of that through nuts and fish, and also take an omega-3 supplementation. And then Miss J goes back to rehab, and about a week later, she shows signs of aphasia and right side hemiparesis, and she's taken to the ICU. And in the ICU, I would again visit her, and a new comprehensive nutrition assessment would be done. And in the ICU, I would continue collaboration with other members of the healthcare team, especially the speech pathologist. In the hospital, the dietitian works really well with the speech pathologist, and it would be really important in this setting. At this point, due to her high risk for aspiration and her hypermetabolic state, I'd recommend starting a tube feeding for Mrs. J. Stroke is considered a hypermetabolic state, and during this hypermetabolic state, things like gluconeogenesis and protein catabolism are happening. So it's really important to try and get some nutrition intervention within the first 24 hours to prevent any further nutrition decline, because at this point, Mrs. J has been in the hospital for about 3 weeks, and now she's critically ill, so she's definitely at risk for malnutrition at this point. So dietitian is such an important part of the multi-professional approach. We are a major contributor to the multi-professional healthcare team. Studies have shown that the average time to reach nutritional requirements is significantly improved when you have a dietitian on board and their recommendations are followed versus when recommendations are not followed. But there are some barriers to this approach, and they include lack of tools for communicating with healthcare team, lack of knowledge of the dietitian's role, and lack of value on nutrition and its place in health and wellness. That's why things like what we're doing here today are so important. It's so important to get all the disciplines together and be constantly in contact with each other. So, thank you, Dr. Wells.
Okay. In response to a patient, OT was never called in to provide service to this individual. So I'm going to be talking about what OT would do for someone in this situation or for this particular client. Oops, one thing. First of all, occupational therapy is the therapeutic use of everyday life activities with individuals or group for the purpose of participation in role and situation in home, school, workplace, community, and other settings. Occupational services are provided for the purpose of promoting health and wellness to those who have or are at risk of developing an illness, injury, disorder, condition, impairment, disability, activity limitation, or participation restriction. OT addresses the physical, cognitive, psychosocial, sensory, and other aspects of performance in a variety of contexts to support engagement in everyday life activities that affect health, wellness, well-being, and quality of life. The practice of occupational therapy include methods or strategies selected to direct the process of intervention, evaluation of factors affecting activities of daily living, instrumental activities of daily living, education, work, play, leisure, and social participation, and interventions and processes and procedures to promote or enhance safety and performance in activities of daily living, instrumental activities of daily living, education, work, play, leisure, and social participation. Now, with stroke line, OT again addresses physical, cognitive, and mental challenges brought on by the stroke, and we also can help the stroke survivor as well as their family in regaining their ability to participate in their daily activities. This can include recommending equipment for a home that can aid the person, evaluating the home for safety and hazard, building their physical endurance and strength, help compensate for visual and memory loss, and provide activities to rebuild self-confidence. The goal of occupational therapy as a part of the rehab process is to enable that individual to return to the life that they had before. Now, some commonly observed limitation that we see with stroke individuals is inability to perform chosen occupation while seated and standing, and this is usually due to a loss of trunk and postural control. Their inability to communicate secondary to language dysfunction, and then specifically our client, because she was aphasic. Neural behavior and cognitive and perceptual impairment, such as spatial relationship, neglect, motor apraxia, sequencing, and attention deficit. Inability to perform chosen tasks secondary to upper extremity dysfunction. She could have pain, contractures, deformity, subluxation, increased muscle tone. An inability to choose tasks secondary to visual impairment. The individual can have problems with eye tracking and eye movement. And then lastly, psychosocial adjustment. Anytime you go through a major health deficit or impairment, how well what we call situational depression is definitely something that can occur. Now, the assessment. Generally, we start out by observing the individual. We will select specific type of assessments and evaluation. We interpret the data. Then we develop hypotheses. We develop goals. We put together the list of individuals and healthcare members of the team that we need to collaborate with, especially speech, PT, social work, and dietetics. Then we will also develop collaboration with the client and the family members in terms of what areas should be addressed and what they would like to see in terms of the outcome for their individual, for their patient. We then will decide on what interventions we want to use, and of course we have to document the procedure as well as document the results. You start out with an occupational profile. We're asking questions: what was the client identity before the incident? What was their interest? What was their life history? What were their values? What was their habit? How did they start the day? What's the most important time of the day for that individual? What roles and rituals? Did they care for others? Did they care for pets? You know, were they working? What was their sleep and rest pattern like? What kind of activities did they participate in socially? Their cultural values, belief, and leisure, as well as spirituality, and the psychosocial adjustment. Then we get into what we're actually called the occupational analysis. We're looking at your basic activities of daily living and your instrumental activities of daily living. We're looking at motor skill, posture, mobility, coordination, strength, grip, processing skills, muscle function, sitting and standing both in static and dynamic, joint stability, skeletal mobility, and their performance tasks. You look at praxic skills. Do they have limb praxic, constructional apraxics, dressing apraxics, communication? Do they need a communication device, or how are they letting everyone know what their needs are? What kind of movement do I have available in terms of developing a communication device? Or they're going to use just their eyes? Do I have any hand function to work with? Looking at cognitive and emotional regulation. Can they regulate, laugh when it's appropriate, or do they laugh at inappropriate time? Do they just cry at the drop of a hat? All of those kinds of emotion are regulated, and we wanting to find out how well the individual can do this. The sensory perceptual skills, looking at tactile, auditory, proprioceptive, vestibular, gustatory, olfactory, visual, body image, figure ground, depth perception. I also want to assess pain. What level of pain? Is it a little pain or a lot of pain? Is it pain on movement? Is it pain when they're doing, actually performing daily activity? The skin integrity, as well as cardiovascular, blood pressure, and respiratory issues. So our goal and objective for a stroke patient is to facilitate competency in basic ADLs and IADL skills, to improve their postural control to perform daily tasks, to increase their somatic sensory proprioception, and or will employ compensatory strategies, will gain necessary strength, endurance, and control of movement of the involved extremity or extremities, will gain visual function or will employ compensatory strategy, and will improve their motor planning. The client and or caregiver will demonstrate appropriate management techniques for the hemoparatic upper extremity to prevent the development of pain and other secondary mechanical restriction. The client and or caregiver will demonstrate appropriate strategies for improving or compensating for cognitive deficit and problem-solving deficits, will gain competency in tasks and activities necessary to resume value roles or to assume new and meaningful roles in the community. Now, during the acute phase is any time once the individual have had the stroke, and most of the time this occur in an ICU unit or a designated stroke unit. And at this point, our primary focus is on preventing secondary complication due to the stroke. So we're looking at mobilization, self-care, skin care, positioning, maintaining the soft tissue lengthening because of the spasticity from the stroke, fall prevention, and we start client and family education at that particular time, as well as discharge planning. So we're talking with the team, trying to get a feel for where is this individual going to go once they have left the ICU unit. During the rehab phase, which can occur in a rehab unit or in a nursing home, because a lot of the nursing homes now have rehab services, we're looking at improving the performance of occupational tasks. We're going to continue with the same goals that we had when they were in the ICU, but now we're really going to look at those ADLs and the performance of those ADL skills, the quality of those ADL skills, and whether or not do I need to teach this person compensatory methods or will the function return. And then we start to bring in adaptive devices that could be used. We want to improve their components of their abilities and capabilities, such as postural adaptation, their upper extremity function, their voluntary movement and function, motor planning, visual deficit, cognitive deficit, and definitely working closely with speech and language in terms of their communication needs. Then we have the outpatient, which is transition to the community phase. At this point, we're looking at discharge planning. We really will focus a lot more on client and family education, letting them know what the individual is able to do without assistance. Do they need moderate assistance? Do they need maximum assistance for different types of ADL activities? We're going to help the individual resume the roles and tasks that they had prior to the stroke. We start to look at environmental adaptation. What changes do we need to put ramp in the house? Do we need to put in bathroom devices? We are looking at other assistive technology and equipment. We want to continue to monitor the development and improvement of their overall physical performance. We want to emphasize what is quality of life and looking at community support and resources. The process of occupational therapy refers to the delivery of services and includes evaluating, intervening, and targeting outcomes. Occupation remains central to the occupational therapy process. It is client-centered, involving collaboration with the client throughout every aspect of service delivery. During the evaluation, the therapist develops an occupational profile, analyzes the client's ability to carry out everyday life activities, and determines the client's occupational needs, problems, and priorities for intervention.
Good afternoon, everyone. My name is Evangeline Carlson. I'm a physical therapist. Okay. And I will be discussing about our perspective on this case in the physical therapy side. Okay, so let's define what physical therapy is. Well, we are in healthcare profession, and we primarily are concerned with the remediation of impairments and disabilities. We look at also the promotion of mobility, functional ability, quality of life, and the movement potential of each individual. So what is our role in the rehabilitation of stroke patients? First, we do an evaluation. We look at what the patient is now able to do and what they were able to do prior to the stroke, and then we formulate our intervention on that, on how to get them back to where they were at or close to where they were at. We also do a lot of education for the patient and also for the family of these individuals. We establish exercise program and also activity program for these patients or for this particular group. So very important when we see patients for physical therapy, we do a chart review. We look at their medical history and comorbidities. It's very important to understand what this patient has gone through, their medical history, because that will affect our intervention, our approach to this patient. First of all, this particular case, the patient has right total hip replacement. We need to know the hip precautions that we have to adhere to, and also their weight-bearing status. Are they able to fully weight bear on the leg that was affected, or are they non-weight bearing on that side? Okay. We also need to understand about their hypertension. In this particular case, Mrs. J has a long-standing hypertension, and it appears to be controlled, but whenever they are on our session for physical therapy, we need to monitor also their blood pressure and their heart rate in response to exercises. Okay? Patient has respiratory problems. It sounds like this patient has asthma, emphysema. This will actually affect the response to to physical activity, and that may decrease their activity tolerance. So we need to understand we might need to start this patient slow. Okay. Recent MI, we need again to monitor their vital signs. Osteoporosis, very important on exercise prescription. We need to know how advanced their osteoporosis is, because we might not be able to use resistive exercises for this patient because of possible pathological fracture if we do use resistance or weights on this patient. Also medication. For this particular group, we need to understand the effect of the medication on the patient, so that uh, for our sessions, we need to know if the response of the patient is caused by the side effect of some of the medications, such as drowsiness, dizziness, headache, those kind of things. Lab and imaging studies and our chart review. We look at the CT, MRI test or X-ray to know how, what was the part of the brain that was affected, and understand, what might be the deficits that this patient might have because of the extent of their affectation on their brain. Social background, living situation. We need to know who lives with them, and prior to having the stroke or the hip hip fracture, were they able to be independent in their walking, in their mobility at home. Other interests and hobbies is also important, because we need to base our exercises on their interests. So on RPT evaluation, we also asked the family or the patient their home. What's their home situation? Do they have stairs? Do they have equipment at home that they were using prior to this event? Do they have help? Do they have provider or caregiver who was helping them prior to this event? Or are they independent? If they're independent, then we need to let the family understand also the deficits that they're gonna that this patient is gonna have, and so they'll be ready when this patient is ready to go home. So again, for discharge planning. Orientation and cognition. For this particular case, the patient is aphasic. Is she expressive or receptive aphasia? Is it then we need to understand, can we communicate with this patient through gestures or maybe writing? And if still the patient cannot communicate with us, then we need to collaborate with a speech therapist. Skin. When we see this patient, we look at any possible, presence of bruising, pressure sores, Foley catheter might be in there, IV. We have to approach this patient depending on what difficulties they have. If they have pressure sores, then we need to address that. Maybe on the wheelchair, we need to put cushion on their wheelchair, and also positioning. Then we need to talk to the nurse about bed positioning and so forth. Pain. We also ask the patient on pain level. If they cannot express themselves, we look at their faces, on how they respond on our movement. Also, we need to know what part of the patient's joints or their body is having pain, and what actually alleviates the pain and what causes the pain. We also look at their range of motion, their strength, and the muscle tone. And this will also then bring us to doing our goals in the future for for strengthening and also for flexibility of this patient. We need to assess function, and that will include bed mobility and transfers and their transitions from one position to another. Gait is also important, and that's our main, as a physical therapist, that's our main concern. Is this patient able to walk? If not, if the patient is not able to walk, then how can we get them to that phase for walking? We usually start with balance and static balance in sitting first, and then probably progress them into static and dynamic balance in standing. Sensory testing and reflexes, that's just helped us to understand more the extent of their deficits. If they cannot feel on the side that's affected, then it's going to be harder. They need to use their other senses and parts, maybe visual, so that they can start looking at their other part, the part that was affected, and that will help with their recovery. Standardized tests, we use standardized tests in balance, FIM, that's functional independent measure, to measure how much help they need for bed mobility, transfers, gait. It's an interdisciplinary test. Also mobility scale, and if they are able to walk, we use time up and go. Now from the impairments and disabilities that the patient that we gathered from our evaluation, then we formulate our goals and our treatment. So for this patient, at first the patient was in inpatient rehab for hip replacement. So our goal for this patient is to be able to probably get in and out of bed, be able to sit to stand, be able to walk. Now when the patient was transferred to ICU, now our approach is different. The patient is not medically stable, so we have to this time we have to maintain their joint range of motion, so they don't get contractures, they don't get stiffness under muscles. We also we try to prevent muscle atrophy, and then maybe we can start doing some bed mobility and transfers, as long as the nurse and the doctors approve and give us an okay to do those, while we're monitoring the vital signs. Now the patient, this particular case, the patient was transferred to a nursing home. When the patient is transferred to a nursing home, our goal is pretty much what we do on inpatient rehab, but it's more of a continuation of what we've been doing in inpatient rehab. So we expect an increase of bed activity, out of bed activity, bed mobility, transfers. We progress their gait. Okay, we do a lot of family training, very important, so that the family understands what the patient cannot do now that they had a stroke, okay, and how much help they might need now that they have the stroke, okay. And also patient education as well. If the patient can understand, at least we educate them on how to adapt to their deficits. Okay. So as wrap up on physical therapy, we work on getting the patient back to their functional status prior to their level of function. So, and the next one will be speech. Thank you.
Okay, good afternoon. So my area is speech pathology, and I have a definition here for y'all so that you can understand better what a speech pathologist does. First of all, we work in a variety of settings, elementary schools, daycares, nursing home, hospital, acute care. We work in a variety of settings. We work with individuals that have speech, language, hearing, reading, and or learning disorders. We work with those that have a hearing loss. We work with those who stutter, have voice disorders or intelligibility problems. We also work with those that are autistic and have brain injuries, those with Parkinson's disease, swallowing disorders, dementia, and social disorders as well. Okay, so in this particular patient, some of the points of interest for me, and these have been discussed over and over again, under some of the general characteristics would be the age of the individual, obviously, the medical history, as we've already reviewed, prior surgeries that they've had, is this person diabetic, what additional medical problems have they had along the way. Medications are very important as well. I would like to know which medications they're taking. Are there any that make them drowsy, lethargic? Because any of those are going to affect my assessment process and my treatment, okay? I'm also very interested in the social and familial history of the patient, okay? I'm always interested in who is the family around, and in this case, the family was very active. They were or are a very well-educated family. That gives me a heads up that this is a family that's going to be there. They want to know what's going on. They want to know how they can help their loved one as well. Some of the specific characteristics that are red flags for me for speech pathology would be, you heard everybody say that the patient appears to be aphasic. Okay, that's important to me. The right hemiparesis tells me that the damage is on the left side of the brain, okay? And you saw from the brain image up there where the left side of the brain was blackened out, so that's where the damage is. The left side of the brain is the part of the brain that holds our language area, our ability to comprehend language, and our ability to express language. So the minute I see somebody that has the right hemiparesis, I know the left side of the brain has been affected, thus the aphasia that we're seeing. The mouth drawn to the left also tells me that there's going to be some muscle weakness in the lips, in the mouth, in the tongue area, which is probably going to lead to some swallowing, chewing, eating difficulties, as well as probably some intelligibility issues. We won't be able to understand them real well if they don't have really good coordination of the oral mechanism. Some of the behavioral characteristics I'd want to look at is this a patient that's been uncooperative, or is it a patient that's been very cooperative? Family cooperation as well, okay? So those are all things that I would look at in addition to many of the others that were discussed as a speech pathologist. When I do my assessment, there's a variety of things that we look at. We look at cognition, okay? We heard Dr. Runyon talk about he asked the patient to follow some commands, but the patient wasn't able to move very well, or they weren't able to follow commands. So cognition is very important. The patient's ability to think, plan, problem solve, their memory, their orientation. Do they know where they are? Do they know what has happened to them? Do they know what year it is, what month it is? Do they know what facility they're in? Do they know their name? all of those basic cognition questions are very important to me to get a better understanding of the patient's cognitive ability. Okay. I also look at language, and as our physical therapist quickly described, we heard that the patient is aphasic over and over. Physical therapy talked about we needed to know if they were expressive or receptive aphasia, okay? So expressive is going to be their ability to communicate. So in my assessment, what I would want to do, I would like to look at their present method of communication. How are they talking? How are they expressing themselves? Are they communicating merely with their eyes? Are they gesturing? What is it that they're doing to express themselves? So I would assess that. I would also see if they have any ability whatsoever to name or to imitate single words, okay? So you would pick up, what are these? What is this? And see if they can name some basic items around the room so that you have a better idea of what they're able to say. In addition to that, are they able to communicate in sentences? Okay, so under the area of language, I'm really interested in how they express themselves and what methods they're using to communicate. Receptively is the ability to comprehend. So this patient was not really able to follow any commands. So that doesn't always mean that they don't understand, because they can understand but not be able to show you, okay? So I like to work with the patient to show me that you understand so that I can speak to you a different way, okay? Because if the patient does not understand anything at all from the stroke, or if the patient does have ability to comprehend, then that's a different way that you interact with the patient, okay? So I would be interested in seeing if the patient could follow some could comprehend single words or follow some short commands, okay? Either by, even just by looking. Show me the TV in your room, them being able to point, okay? Where is your wheelchair? Where is your bed? Do you see the clock? And seeing if they can point or if they can show me with their eyes. That way I know that they are able to understand, okay? With comprehension, with receptive abilities, you have to be a little bit careful, because sometimes, and you've seen the word over and over, the apraxias, okay? So if you have a patient that has apraxia, especially a limb apraxia, okay? And in this case, the movement that the patient has is on the left side, okay? So if the patient has apraxia, and if they have a limb apraxia, they're not going to be able to voluntarily execute the command, okay? So if you say, show me your eyes, and you want them to point, show me the TV, and you want them to point, they may be able to understand you, but because of the apraxia, the limb apraxia, they may not be able to get their brain to send the signal to move the hand to point to what you need to point to. So they might just be there looking at you, and you think, oh, they don't understand me, okay? So I take great effort in distinguishing between somebody that can comprehend but is apraxic and somebody that does not comprehend at all. I think that's real important, okay? So in addition to that, the simple words, the simple commands, and we go into multi-step commands, or even following the flow of the conversation, okay? Sometimes they're not able to express themselves, but they're looking at you, and you're saying, are you doing okay? And it appears like they're listening through their eyes and all. It appears that they're able to follow the flow of the conversation, although they're not able to tell you so, okay? So for the aphasias, I would assess those under the area of language, okay? For an expressive aphasia or for a receptive aphasia, okay? Expressive would be Broca's aphasia, receptive would be Wernicke's aphasia. I would also assess written language, and then it depends on the patient. It depends on the level of education. It depends on, is the patient left-handed or right-handed? In most cases, they're right-handed, and with a lot of the patients that have aphasias, the right hand is paralyzed, there's paresis, they're not able to hold the pencil, okay? If there's some movement there, I would like to, and traditionally do, assess their ability to write their name, to write an X, to draw circles, to draw lines, to do something, okay? Especially if this was a person that wrote quite a bit previously, okay? I would also assess their articulation or their intelligibility. So when this patient speaks, can we understand what they say? Okay, so I would look at that percentage. Can we understand this patient 50% of this time? Or does this patient talk and talk and talk and talk and I don't understand anything that they're saying? Okay, so intelligibility or their ability to articulate clearly would be something else that I would look at. I will do an oral mechanism exam, okay? Looking at the oral structures, I check to see if they have dentures, wear dentures. A lot of times they do have dentures, they wear dentures, but they don't have them in when they're in the hospital, okay? That's important. I check on that. I look at the range, motion, and strength of the articulators, the movement of the tongue, the movement of the lips. Is there enough strength there? Okay, can they move them quickly? Is there enough motion there when they utilize their articulators? If there's not, again, that tells me, okay, they're probably going to end up having chewing and swallowing difficulties if they're not able to coordinate the oral mechanism very well. Okay, and so traditionally, when you have a stroke, it's going to cause some weakness in the oral area, okay? And we know this by the drooping for this particular patient. The ability to follow commands, that goes along with the praxis that I discussed earlier. Traditionally, when a patient will have a limb apraxia or not able to execute the movement on command, okay? If we see it in limb, we typically see it orally and verbally as well. Okay, so when I tell the patient, stick your tongue out, let me see you smack your lips, when I have them do that, the same types of difficulty that I would see with the limb apraxia, I would also probably see with the apraxia, which would be oral or verbal. Okay, so when you say, okay, we're going to take your medication now, here, drink some water, they may not be able to prepare the mouth to do so, okay? So just remember the limb apraxias go hand in hand with the oral and the verbal apraxia. So the apraxias that a physical therapist or occupational therapist might see with the limbs, well then I might see those over here in the oral area. Swallowing. With this particular person, they had a difficulty swallowing, okay? And as part of my assessment, I would check to see if they're able to swallow, okay? I would check them for different consistencies with liquids, all right? So with liquids, we have our thin liquids, which are just our regular liquids that we drink, that you and I drink every day. When you test these, there's thin, there's nectar, there's honey, and there's pudding, okay? Due to the amount of damage that the patient might have in the muscles that are utilized in order to chew and swallow, okay, they may not be able to take these consistencies very well. Okay, so you test them at different levels to see if there's choking, if there's aspirating, if there's throat clearing, anything like that that would indicate that this patient is having difficulty swallowing. Okay, that's a really, really big red flag that goes up because there's the high risk of aspiration. With continued aspiration, then you have the development of pneumonia. Okay, so the ability to swallow well, swallow safely, and swallow at different consistency levels is very important, and that's something that the speech pathologist would do. In addition to assessing liquids, we would assess the consistency level for foods. Okay, their ability to chew, manipulate, solid foods, regular foods like you or I eat, soft foods, or foods that are pureed. If you see difficulty with any of those, you always want to downgrade the diet so that it's a diet that would be easier for them. If you continue to see difficulties with these, then there's always the modified barium swallow study, which is a x-ray study that's done through the side, through the front, that shows the patient actually chewing and swallowing and drinking different consistencies of liquids to see exactly where the liquid is going or where the food is going, so that we can determine if, in layman's terms, if it's going down the wrong way, so that we can then put them MPO. Okay, so this would be a really important component and a very crucial crucial part of the assessment, especially for the patient's safety. Okay, so my goal for this patient would be to communicate again in some way or another with the family, friends, staff, etc. We would also work towards regaining the ability to eat and swallow somehow. Okay? As a speech pathologist, when I come into the rehab setting or the hospital setting, for any of my patients, I would check with all of these professionals, okay? When I go in and I'm concerned about patient X, I would immediately go over to the nursing staff and say, how did patient X sleep last night? Were they restless? Were they up? What medications are they on? Were they out of control? Did they have to give them medicine to calm them down? Okay, I would check with the dietitian. How did they eat? How are they swallowing? How much of their food did they eat? Did they eat 20%? Did they eat 80%? Okay, I check with the occupational therapist. How are they doing in therapy? What were you able to do? Were you communicating with them? I always make contact with the CNAs and say, this is how you need to speak to this person. This person can understand you. It doesn't look like they can, but they can. So I've developed a little communication board here. It's always at the table. This is how you use it, okay? So I would work with the CNAs. I would work with the nurses. When I see that patient being taken to physical therapy or occupational therapy, I'll go in there and say, where's their communication board? Y'all can't communicate with them unless you take the board or so that I have developed, okay? So whatever I work on in speech therapy, I make sure that every other professional knows. There's no sense in me working on it and establishing a communication method with this patient and it not being used with the nursing staff or with any of the other therapies, okay? I would work on cognition, getting the patient more oriented. We talked about maybe there was some confusion, not knowing where they were. I would want to get the patient to understand where they are. I would want to establish some kind of language communication system with them, okay? It is extremely frustrating for a lot of stroke patients that understand, but they're not able to speak expressively. So sometimes just even being able to point to pictures, to point to yes, no. I've put boards together where I would tell the therapist, you need to ask them, are you feeling sick today? And the patient can point to yes or no, okay? Did you sleep well last night? Yes or no. That's such a relief to the patient knowing that they're able to communicate some of their thoughts in one way or another. So I would work on establishing a language system, okay? Many times when I finish working with patients, I come out and say, you know what? This patient understands. You don't think the patient does, but this patient has shown me that they do have some ability to comprehend. And again, remember, just because they're not able to express their thoughts does not mean they're not able to comprehend. So I would like to inform the different disciplines of the expressive abilities and the comprehension abilities of that patient. I would also work on intelligibility, working to get the patient more clear in terms of how they articulate. And even if it's through just single words, practicing the names of their children, practicing their names, the names of their spouse, anything like that, and utilizing methods to increase their intelligibility, okay? And then obviously the swallowing, in hopes of regaining some ability to eat, even when you go from being pegged to eating just pureed food. Okay, that's a huge accomplishment for many patients to be able to have food orally again. So that would be a very big goal, to move that patient from that one step to the other. And again, none of this, you can't do any of this without having collaboration from all the other disciplines. Thank you.
Okay, so they're leaving when social work comes up here. Thank you for leaving. Or actually, thank you for coming. Good afternoon. My name is Dr. Gonzalez, and believe it or not, social services and social work is incredibly important in this team, as every department is. For social work, well, let me say this before well, not a disclaimer, but maybe a reality. In hospitals and nursing homes, there are social services departments. They're not always done by social workers. That is really important to understand, I believe. Social workers are trained to look at a person in their environment. And in this case, we're wanting to see the environment that the patient's going to return to, or the environment that they're going to end up in, and looking at the strengths and support that they already have. So that's a really important thing to understand, I believe, unfortunately. Now, social workers also, by the way, social workers do much more than just take the kids away, as television likes to still focus on. We work in hospitals, with police departments, with victim services. We work with home health, with hospice. We work in different parts of the schools, in employee assistance programs, of course, all over the mental health field, and all over the community. In social work, there's 3 levels of service. We have the micro level, which will be the individual and family. We have the meso level, which is smaller groups, and we have the community level, which we call the macro practice. So we're all over the place. Now, in this case, some of the things we've already heard, and what a social worker would do is do a psychosocial assessment, which would be a summary of everything we've already heard. All of that stuff we need to know. As a social worker, I need to know everything that everybody's doing and understand it, so that I can then make sure that in hopefully returning the patient home to hopefully live back independently, that they get everything that they need to be able to do that. So I'm going to consult with the patient. I'm going to consult with, in this case, the husband and the daughters. Now, one of the things a social worker will do is, in talking with these informants or these folks to gather information, you're going to learn stuff that maybe wasn't on the psychosocial assessment. So in the last hour and a half, I learned that there's also a brother that hadn't been talked about, or I hadn't heard about till today, that and isn't as involved as the 3 daughters that we'll get into. That's important because of family dynamics. And we need to understand that so that we can help the patient and the family, again, in this discharge. One of the other things that I'll point out on this slide that is important to know is that her father passed away of cirrhosis of the liver secondary to alcoholism. So we would want to understand that because of possible family dynamics that may have been transferred over generations. Okay, that might give us an idea of, for whatever reason, the brother's involvement or non-involvement. Okay, and it's more, that'll come into something later when we get to the rehab part, but again, that helps me understand the approach and helps me understand not just the patient and the husband, but again, in this case, the daughters that I'm going to be working with to get this information. So with this patient, she does have a lot of good support. and that's a really good thing. We already heard about the daughters all being employed in healthcare. So there's a good understanding of what's going on, but one of the things that we have to also consider, though, is the professional boundaries issue, because it's one thing to do your job as a professional in healthcare, but it's another thing when your family is the one involved, and you're working and you're doing this as a family member and not as a professional. For this patient, one of the things I'd want to look at, a couple things that would be important, is he's a retired RN, 3 master's degrees, very, very intelligent, and we also, as we've already heard, would also want to know what hobbies are and what she liked to do. We'd want to look at what her income is and insurance. Well, she's a retired professor, so she has retirement and also Social Security. She has Medicare and Blue Cross Blue Shield. So fortunately, in this case, she's going to be covered pretty well, all except for long-term care insurance, which we'll talk about in a little bit. Now, we've heard about advanced directives, and this is something that the social worker will do in a hospital with just about every patient. Basically, an advanced directive is you expressing your wishes about essentially how you would want to die if for some reason you couldn't make that decision. So you, if you didn't want certain types of treatments, you could put that down in paper, and that way the doctor would know, or doctors would know. Or you can designate somebody, which would be a living will. The power of attorney. You can designate somebody, and they would carry out your wishes to do that. And then, of course, the big thing with both of these, these directives, is that the family, all of the family, including the doctor, are on board with the patient's decisions, so that there's hopefully no issues with that. Now, a DNR is a do not resuscitate order, which is also something that really becomes important with older persons, because if you're needing to perform CPR on them, that could really hurt them much more. Because again, remember, with an older person, their bones are not as strong as a younger person, so that could result in other injuries. So that would be something to consider. Now, with the insurance, this is important to understand because it's going to influence the type of care that we've already heard on the discharge plan. Okay, the discharge is to go to a skilled nursing unit. Now, a skilled nursing unit is normally a 21-day stay. Medicare pays for that. Medicare insurance is, Part A is the hospital insurance. Everybody qualifies for Medicare as long as you work 40 quarters, or basically 10 years into the system, similar to getting Social Security. It covers about 80% of just about everything that you might need in a hospital stay, including home health. Medicare Part B is a supplemental to that. That's something that you would pay for to cover the other costs. Now, the Medicare Advantage plans are when a person can choose a company to administer their Medicare. Those are, okay, so in being opinionated, regular Medicare is pretty much good. These Advantage plans aren't bad as long as you're essentially healthy, because depending on the plan, they might restrict certain medications. So you might have to understand that. So depending on what pharmacy thinks is important, well, certain things they may cover, may not. So it might influence the pharmacist to have to prescribe a different medication than, so that it's covered. Okay, Medicare Part D is a prescription program that again works very well. It helps to a certain point of payment. And then it doesn't help so much until you spend a lot of money, then it helps you again. Again, unfortunately, that is something that... now, one other thing that can happen in a lot of communities is there are prescription assistance programs, which a lot of times seniors will qualify for, which can be helpful, and they can get medications at a lower cost. Now, long-term care insurance is the last insurance that helps, and what that is a separate policy. For you young people, once you get a job, lock into a nice lower rate, and keep it, because it would provide something like $100 to $200 a day. And nursing home care right now is about $3,000 to $4,000 a month. That insurance does not cover. That's all essentially private pay. And we'll, there are some ways to qualify for aid, which would be Medicaid. Medicaid is another insurance that is available if a person doesn't have a particular income. In this case, of course, Medicaid doesn't apply. Now, we've heard about the skilled nursing unit or the rehab, which the rehab that our patient was going to is to continue PT, OT, speech therapies, and that's going to happen in what's called a skilled nursing unit. I'm sorry, a skilled nursing facility. It is sometimes referred to as a SNF. Sometimes they are located in hospitals. Sometimes they're located as part of nursing facilities. So they're going to a nursing home, but they're not going to a nursing home for long-term care, which so there's a difference that essentially in going to this type, the nursing home for this type of care, they are going to come home. Okay. Now, if a person goes to a nursing home, needs nursing home placement. Now here, a nursing home is normally the highest level of care for an older adults outside of a hospital, including getting in and out of bed and providing assistance with feeding, bathing, and dressing. And this is essentially, when a person goes to a nursing home, they're not going to go back home. This becomes their home. Now, that doesn't mean they can't live there and enjoy life. They can, okay, but that's a whole separate discussion. So that is now what we would also do, depending on the referral for either of these, is we're gonna, as a social worker, we're gonna gather all the information along with where they live on the availability of the different type of skilled nursing facilities that they can choose from, or the nursing homes. So what we can't do legally is say go to this one, but we can give them tips on what to look for in a nursing home or in even a skilled nursing unit to get some ideas of where they want their loved one to go to. Now, in getting through the skilled nursing unit and then hopefully going home, then we're going to involve home health, which again would continue possibly any of the OT or PT, even speech therapy and other things. And in this, we're going to want to know about the, as we already heard, the ADLs and the IADLs to see what else do they need. Do they need a provider? Do they need assistive devices so we can make those referrals for any of the medical equipment? All of that again is knowing again their insurance situation is then going to help with making these carrying out these referrals. Now, one of the other things that could happen is hospice, and I believe in this case that eventually did happen with our patient. Now, hospice is the healthcare services that meet the needs of a dying patient. In hospice, it's what's done is palliative care, and it's care directed to improve the quality of life of the dying person, including the individual symptom control and spiritual support. Now, and bereavement support. With hospice, it's not about curing anything anymore. It's about mainly what was also referred to as comfort measures, to make that person as comfortable they can be as they're dying. That is a very important decision. It's also, again, a family decision too. In all of this, we can't forget, and we've actually heard this already, is that our patient is the patient and the family. So not just the patient themselves, okay? And again, the making that decision for hospice can be, it's difficult, but at the same time, it might be something that's best for the patient and the family, okay? Now, hospice is covered, home health and hospice are covered by Medicare, okay? Actually, hospice covers very well, and a person can choose, and a person and family can choose where they would want their loved one to spend their last days. It could be a home health, a hospice facility, it could be a nursing home, it could be home. So that's their choice. And the last people that we need to help with is the caregivers. Because remember, what the caregivers are doing is they're juggling their work, their own family responsibilities, their own health. In this case, they're very, very close to, their work is very, very close to what's going on. So it's not always possible for one person to care for 24 hours a day. There are day programs, there are home care services and respite care, which can help give the caregiver a break every once in a while, or caregivers. A lot of times caregivers and families will sometimes come up with a model that's mainly rotational, where each person can, hopefully contribute. And sometimes that, depending on the family dynamics, that can work out very well, and sometimes it maybe doesn't all work out so well. There may come a point where medical needs become too great and home care needs are unable to bridge the gap and become too expensive. In this case, sometimes that's a point where a nursing home placement has to happen. And again, the bad part about that is the financing part of it, is how it's going to be paid for. The last thing that I think that's important, and it'll be covered here next, is with the husbands and daughters could use a referral for some counseling with the help with grief issues. Now, hospice does continue for the family up to 6 months after a person passes away, to offer some support, which would include the social support, the bereavement support, and spiritual support. But thank you, and I introduce to you now Dr. Jerry Fisher.
Well, it's an honor to be here. Such fantastic colleagues that have gone before me and will go after me. So let me just start off with what is the role of the rehabilitation counselor? And in an interdisciplinary team, it is to give guidance to the team members in assisting the person with a disability in coping and adapting. So we're really looking at the psychological and the social issues that this person is facing, but not just the person, the caregivers also. And by caregivers, as we've been talking, that would mean family members, partners, significant people in their life that are there and that they are helping this person cope with that disability. Rehabilitation counseling is a systematic process which assists persons with physical, mental, developmental, cognitive, and emotional disabilities to achieve their personal, career, and independent living goals in the most integrated setting possible through the application of the counseling process. Now, one of the major issues I saw in the case of Mrs. J would be anticipatory loss. This is a psychological process that, again, not only would Mrs. J be going through, but also the caregivers. It is a reaction to the nature of the possible progressiveness of the disability. If a disability is stable, generally people are able to cope, and they'll set up a routine and they'll set up a psychological process that'll stabilize with that. But if there's something like the stroke, there's a possibility and there's an anticipation that things will get progressively worse. And the stroke here would have alerted both the Mrs. J and the caregivers to this. What generally happens, though, is caregivers may start to anticipate this succession of losses and on the physical health, the mobility, the independence, and social interactions. Their response may be to withdraw, and that's where counseling will definitely need to play a part of this, because what they are trying to do is protect themselves from anticipated pain and anguish that may come. So they start to withdraw from that. And of course, what we would give is supportive counseling, allowing caregivers to give voice to their feelings and alleviate the tension and stress. And again, Mrs. J would also go through this too, as she anticipates the continual losses that may occur. There's this tendency to withdraw psychologically and social, and again, it is to try to avoid the pain and anguish. What else would be very important psychologically and socially in this case is the stages of coping and adapting. This is a stage theory, and these stages are not successive. They can be in any order, but generally they do follow a certain progression. And again, the stages are also applicable to Mrs. J and then also applicable to the caregivers. The very first thing is the initial impact. This would have probably have happened as Mrs. J was in the hospital and it was uncovered that she had a stroke. And then starting to realize, well, what does that mean for me? What is that going to, how things are going to progress from here on? And again, the caregivers hearing the diagnosis of stroke would also have a little bit of that initial impact, which generally is shock and anxiety. Interventions for counseling would be to communicate with the client, support and reassure the client, to be there for them, to make sure that they know that they have somebody on their side and that somebody's going to be there for them. Comforting gently, reflecting on and clarifying a client's statements and concerns. At this point, they may be just blurting out things and be thinking about things that may not be relevant to where their situation is right now, but you want to be able to clarify that for them. You want to reassure them. Maybe help them with some muscle relaxation, particularly if their tension is great, and breathing exercises. And our wonderful physical therapist and OT people could help us do that. Also, try to give some explanation of what is happening and what to expect. The next stage would be defense mobilization. This is generally called bargaining and denial. At first go around, it would be very important to accept the denial. What happens is this is a very much an ego protective state. There's been so much happening to both the caregivers and to the Mrs. J that they're going to be in denial. You know, they may be thinking, well, I'm going to be out of this hospital in a day or two. And you're thinking, whoa, you know, you have a very complex case here. And even the caregivers might think be in denial that, well, this will be over within a week. What's happening there is that they're protecting themselves from the massive tensions and emotions that are welling up. And it is just kind of like to put those on hold, and that's what denial generally is. So the counselor would accept the client's denial, but also start to import relevant information to the client about his or her impairment. And again, and to help them understand the depth and the complexity of the disability, the stroke, and what that's going to mean in successive weeks, maybe months. Obviously give support and education to the client and the caregiver. And if still the denial persists, there would be some gentle confrontation to help them break through the denial and get them to some sort of self-awareness about what does this disability mean, how is this going to progress for me and my caregiver. The next stage is initial realization or recognition. This is where mourning starts to set in. People start to realize, I have lost a significant part of my life. In this case, understanding I may not ever go back home. I may have to stay in a nursing home. I may have to go to the rehab hospital and then to the hospice. And people are going to mourn the loss of that independence. Generally, when people start to realize the complexity and the depth of their disability, they are going to become depressed. And we call this internalizing their anger. What the counselor would do would be encouraging the client to express feelings of depression and guilt. Again, making it known, letting them speak about it is a very cathartic thing when people bring those emotions to the light of day. Promoting acceptance of the disability, talking about, let's talk about what you can do, what you have left, and looking at the positive sides of where they are at now. Reinforcing the client's strengths and assets. Stress management training, helping them understand the emotion of stress, and when that comes up, what are some of the things they can do to dissipate that stress and also get them back to a more healthy frame of mind. Not permitting depressive and dependent habits. Again, making sure that they are following their personal hygiene. One of the first things to go when people do become depressed and they start to mourn is they do let their hygiene go. And so you'd want to make sure that they are, if they're in the hospital, maybe they get their hair done once a week. Or somebody comes in and they make sure that they're at least looking as presentable as possible, that they are not sleeping all day, that they are actually up and active and they're engaged. Reinforcing interpersonal and social contacts, helping them reach out to their caregiver and other people in their family. Again, there's that, if they withdraw socially, that is going to be a very negative thing. Setting concrete and short-term goals. Again, this playing off of the fact that the person has some cognitive impairments, just short things that what are you going to do today, how's the day going to go for you, and not looking for really long-term things. And of course, interrupting clients' irrational beliefs. With this, one of the more common irrational beliefs was, my life is a catastrophe, my life is over, and trying to dispute that and say, no, it's kind of unfortunate now, but what can we do? What do you have left to do? That type of thing. As the person in the last stage kind of internalized anger, now you might see some anger coming out, some retaliation or rebellion. People are going to be really upset with the situation they are. Why does this happen to me? I don't deserve this. They may be very upset with the caregivers and the people providing the services. They're like, I don't know why you're here in my room, just leave, things like that. What the counselor can do is meet this aggressive individual with kindness and firmness. Listen to their anger, but doesn't mean that you need to respond to that. And the counselor definitely needs to be in control of their own emotions. Avoid direct confrontation. It's not a place to get into a shouting match with the client. But teach the client to channel their aggressive behaviors into productive activities. Again, you have them do things that are going to be productive. We talked about them getting in touch with their greater social network. They might be wanting to write letters. I worked with a young woman who was diagnosed with progressive cancer, and she had a tape recorder. Actually, it was a digital recording device, and she was giving her life story for her daughter and her daughter's children so that they would know what her life was like, what was meaning for her life. That would be a nice way to channel some of that energy and aggression that's there. Help them build tolerance for frequently occurring daily frustrations. And there are so many of those, like getting up may be very painful. We heard the osteoporosis. That could be a very painful process, and that's going to happen. And helping them do some mindfulness about getting into a zone so they don't feel that pain, and trying to build up some tolerance for that. And of course, working on some relaxation techniques. The last stage, stage 5, is reintegration or reorganization. And on the cognitive, this is acknowledging that, yes, I do have this disability, my life has changed. On the affective substage, it would be coming to acceptance. Emotionally understanding that this is my life, And then a behavioral stage would be adapting, which means is trying to deal with the circumstances as they are and trying to go forward. Again, the counselor is trying to foster exploration of new realities, work towards realization of his strengths, teaching problem solving, etc. Major coping strategies here would be reframing the problems that the client is facing into challenges. And if they are in the acceptance stage in reintegration, people with disabilities and caregivers can shift their responses to successfully responding to what is, instead of magically wishing for reality to change. Really, so it's like to bring them to the concrete things that these are happening, what can we do, and not pin their hopes on magical wishing. Caregivers and disabilities are encouraged to rewrite their own stories, and instead of asking, why did this happen to me, can I see any way that I can use this situation to my own advancement? What can I learn from this situation? What can I do that might result in a more uplifting experience for me and everybody involved? Helping them change their self-talk. This is important. This is about disputing some of those irrational thoughts about themselves, like my life is over, there's nothing left, it's been a terrible experience, and try to encourage more positive self-talk patterns. And the counselor could get in there and help that, develop that. I want to talk a little bit about the stresses on caregivers. One of the things is those stages, like I said, are not lockstep. They are, people can be in very different spots at the same time. And you can see how the dynamic of that and how complicated that would be. If somebody's in acceptance, a caregiver's in acceptance, but another caregiver is in retaliation, rebellion, you're going to have some friction there. The dynamic is going to be very off, and that's where a counselor could come in and help resolve that and help people get on the same page. But the caregivers are going to be feeling overburdened, engaging in extensive caregiving, frustration and lack of communication. They need to take care of themselves physically and emotionally, because the fatigue can set in. They need to also realize that other people are involved. They need to be able to have time for their significant others. And of course, they need to realize, because they may be involved so much in this caregiving, that they their partners may start to distance themselves from them. And of course, the siblings of the caregiver may start to feel frustrated and left out. And the last psychological thing I want to leave you with is contradictory, confusing messages from disagreeing significant people, caregivers, complicate the person with the disability's attempts to recognize order and predictability in the ward. And that's why a rehabilitation counselor would be essential to come in and work with the family and the person with the disability. All right, thank you.
Good afternoon. I'm impressed that all of you have managed to stay this long through this talk. What I want to do is kind of wrap up what happened to Mrs. J. I like to say she transferred to heaven on September 30th, 2012. She died at home with her family around her. All of her children, her husband, her grandchildren were all there that day. And she died peacefully. And she was conscious up until the end. One of the things I want you guys to learn to take home about this situation is you need to learn to speak about death to your patients in a compassionate way. You need to support the patient's wishes, the family wishes, and there's going to be conflicts in the family about end of life with care, and you need to get help with conflict resolutions. One of the ways I've learned to do that with my patients is on their initial visit to my office, as I'm doing a history and physical and I get to the social history, one of my questions is, how do you want to die? The bottom line is, nobody gets out of this life alive. Eventually, we all have to go to heaven. So where do you want to be? Do you want to be at home? Do you want to be in the hospital? And of the thousands of people who've responded to that question for me, I've had one person say, oh, I want to die in the hospital. I don't want to burden my family at home. Every person to every other patient has said, I want to be in my own bed. I want to be at home. But this is a way to open the dialogue about what they want, and it kind of moves into helping them get an advance directive, a do not resuscitate order, and a durable medical power of attorney so that someone else can help make decisions for them. And the families have to be involved in this. The spouse has to be involved and on target, and all the family members have to be involved. And it's when we have family members that don't agree with each other that sometimes conflict starts, and hospitals have committees that help with this, and you just have to begin to talk with people about end-of-life issues and how they want to spend their money. The last point is with stroke care. You mentioned $65 billion a year spent on stroke care, and I did see some statistics once that show the money if we spend on prevention of strokes is about 5% of that $65 billion. Strokes are preventable, and we have to start changing our thinking in healthcare towards more prevention to reduce that $65 billion we spend on strokes. Thank you for all the time that you spent with us this afternoon. We're running short on time. I don't know, Melinda. We have 10 minutes. Do we have any questions? Do you
If
guys
anybody has a question, we have 10 minutes, so you can come up to the mic, please.
Maybe nobody has a question.
I know this was a very long session, and as Dr. Renaud said at the beginning, it was our first session, and we appreciate the students that were here and those that were not here, faculty that were here. If there are no more questions, I want to thank the faculty.
Thank you very much.
I am so honored to work with you. Awesome. To see, please turn in your evaluations outside, and we're going to do this again next semester, but the students will be in charge next time. Thank you.